We are going to start by talking about what the situation looks like on the ground, and I would like to invite up our first two guests, Johnny Ohta and Dr. Taryn Hansen. Please come on up.
All right.
Okay, so here's, oh wait, check.
Check.
Check. Hello. Okay, so here's some information so you know who they are. So they work at the Kaiser Permanente clinic at YouthCare Orion Center, and they help young people who have an addiction get onto medication to help them recover. And now, I said that they work at the clinic. That's not entirely accurate because they run all over the place, from hither and yon, chasing after young people, driving them to housing, getting them phones, helping them with their court records. I mean, anything that they need to support their recovery, right? So thank you both for being here so much. I'm so happy to have you. And I want to start talking about the young people themselves. A common narrative, as you may know, as the audience may be aware, is that we hear of people getting addicted to opioids through the pathway of they have an injury, they go to the doctor, they get onto opioids, they start taking more and more and more, they switch to heroin. I understand that the trajectory might be a little bit different for some of your patients. So can you tell us what are the common themes in the stories of the young people you work with as far as their path to getting addicted to fentanyl and meth?
You want to go, Doc, or you want me to go?
I think I can, you have a lot to say because you've been doing this longer, but I was going to just say it. There's a couple things. I think fentanyl has totally changed the drug landscape here in the Northwest in King County. I mean, it arrived since we've seen a huge change in the last 2 years, and it is here. If you don't think it's in your neighborhoods, you haven't been looking for it. It is, and if you don't see it there, you can get it on social media, and that's where a lot of our kids are getting it. So the pathway does look very different than that pathway we hear about right now when we talk about prescription opiates. So there isn't one path, and I think that's what Johnny can talk a lot about with the young people we've seen, but there are some, like you said, some common threads. And so, adolescence is a time where a lot of people are seeking rewards and risk-taking, and there has always been this idea that there's a time for that experimentation. But young people face something totally different today, which is that it is a lot more dangerous. And so it's dangerous whether they're new to opiate use and they're trying it, and they could have a fatal amount in that one pill they are taking. So this one pill can kill idea. Or it's dangerous because if they keep using it, they're at risk of a rapid onset opiate use disorder. And so kids who never thought they were going to have an opiate use disorder, they're not prepared for it, their parents aren't prepared for it, and our systems aren't prepared for it. We have rapidly accelerated into this crisis, and it's only increasing, so we are not at the tipping point yet.
Mm-hmm. Yeah, thank you. I actually work for a place called Ryther. I've been working at 2 drop-in centers for homeless youth for a long time, the Orion Center and the University District Youth Center. And so I can jump on that a little bit, what Dr. T said, but also, the thing about the prescribed medication that somebody was given and then it led to all this other stuff, that did happen, and it happens to some people. We work with young people. We work with young people between 13 and 25. And what Anna really wants me to talk about is some things that I've told her, which is really that we got all of these young people. And so I work with homeless youth and young adults. And then all of a sudden, a year and a half ago, 2 years ago, I worked with the juvenile justice system a lot. And all of a sudden, out of nowhere, these kids are smoking weed, drinking, going to parties, and bam, they are crying in the basement in withdrawal. And it's just like that, like in weeks. And they're, some of them are cool as slick, so they can sneak around for like 6 months. But, a lot of them, they can't even like sneak around for that long. Like people, like smoking weed and hiding it from their parents and stuff. And all of a sudden, bam, they're just in withdrawal, crying for help. And that's a really different thing than, obviously, we won't get into it that much with the OxyContin thing that happened, and with some other adults that put opiates in their body for some other reason and thought their brain did this thing. These young people that we work with, And these now are some of them are formerly homeless and homeless youth, and then a bunch of these kids were like in the 10th, 11th, 12th grade, and all of a sudden, bam, and it hit them so quickly, and we are, able to talk to them. I work with a lot of parents, but I'm usually trying to find parents that are like, this kid has not been home for 3 or 4 or 5 years or been kicked out of their house and all that. Now we got this whole set of people, a different group of people, and quite a few of them actually through the juvenile justice system. And just having a doctor, and just really quickly, like that day, I just go over there and talk to the kid, because we want to talk to the kid. I like talking to parents, but not really as much as I like talking to young people. Really, the parents there's all this stuff, and I just want to say, like, and I had, anybody in this room who has suffered a loved one, who has lost a loved one, who has watched their people suffer from addiction and also die, and there are people in this room that has happened to. I just want to acknowledge that because I had 2 friends die this year, and I work, pretty overly exposed to people in addiction, and it's just brutal, and the brutality of this particular wave. And we've been through some waves. I've been through a lot of them.
Yeah, and I want to pull something out of what you mentioned there that's really important to know about fentanyl, is that the trajectory of the addiction itself is much quicker than, say, with heroin. So you start using, and then because of the factors in the drug itself, you're much more addicted much quicker than something like heroin. So another right?
No, yeah.
So another factor, another couple factors that I want to bring up different with fentanyl now is that something that I've seen and that I've learned from you all is that the path to fentanyl addiction is made very smooth by a few things, being the low cost of the pills, the easy availability, and this nice little packaging in the form of a baby blue pill that looks like a pharmaceutical company made. For the young people you work with, how much do those factors influence their path to addiction?
Well, I think the first part you said clearly, right? It is a more addictive substance. So it's more potent and it's shorter acting, and that makes it just highly addictive and accelerates everything. So there's kids, I guarantee, that would not be where they are if it was another drug, because it has just accelerated this period where they end up with an opiate use disorder and all the things that come with that, right? And so then you add on that it comes in a pill form, and it just doesn't seem as dangerous. Pill using is not as stigmatized among adolescents, and so if you can get it and you see it at a party or you see somebody using it, some of them do not know it's fentanyl. We work with a lot of kids who do know it's fentanyl, but even that, they're out there and they're like, I would never use heroin. I would never, they list all these other things they would never use, but they really cannot get away from the fact that it's this pill that's easy to use, easy to get, easy to use, to also the route of administration. So if you're smoking it, they can use it when they're at work. They use it in the bathrooms at school. There's all these things that just make it a perfect storm for adolescents accessing this drug that wouldn't have had that same risk before.
Yeah, I mean, and people here too. I mean, I had needle exchanges at both my sites, had to fight for them for years, had them for a long time, use them as an access point and it was really amazing. But it was all people shooting drugs. And really now, like, I have a bunch of those other young people I've worked with for years. There's like more than half of our young people would never even imagine shooting a drug. And they are like stuck on fentanyl pills, like totally addicted, been to treatment, overdose, got out, jail, all the things. They're like between 17 and 20, would never use a needle. And so that's a big marker of the difference of what's happening.
And so many of them have said over and over when we start meeting them, because we meet them when they're in crisis, and they're like, I wish I had known. I wish somebody had told me. And it's not necessarily that it's deadly. Like, some of them have known that it's deadly. It's that I wish I had known it was going to be this hard to stop. It was going to take over this much of my life, and that it would change really everything for me.
We mostly meet them in withdrawal. Actually, with Dr. T, like I've done a lot of other work for a long time, but then when Dr. T started rolling with me, it's really, we meet them in withdrawal, and they're like, they're hurting, and it's that first time that they realize that they've been taking a drug that causes withdrawal, and that, as many of us that have done this for a long time, we've witnessed it many times. But with these young people, they are like, this is the worst thing that ever happened to me in my life.
Mm-hmm. Mm-hmm. Now, you do see people recover. Your job is to help people recover, and so you have had a number of patients, right? I mean, more than a number. A lot? Can we say a lot?
A lot of it. Oh, we talk about the long game. So
the long game.
So
okay.
I don't know that people graduate from our program. We're not very good at graduating people
because
we like to
graduate
stay.
a couple right now, but yeah.
Yeah. So you spend years with people, right? Can you talk about those success stories and what does it take? What does recovery look like? What does it take for them to stop using, despite these horrendous withdrawal symptoms, and to stay off fentanyl? Or other drugs, for that matter.
I mean, the first part is hours and hours and hours of a multidisciplinary team all around case management and responding. First we respond to the crisis that they're in. And then once you build that relationship, they can unroll all the other things that they're looking for. So once you're past the crisis and you're past the survival, then we can talk about the actual things. But the first part actually takes a lot of time, like how do we meet them? How can we get to them? Do they have a phone to call us back? Do they know what insurance they have? I mean, for us, it's very different because it's young people navigating an adult system that they have never used. So a lot of them don't know how to pick up their prescription or don't even know who to call. We have a lot of low barrier clinics, but they have never even walked in the door of most of those. And so our first part is really just like, how do we build a relationship? How do we stay in touch with somebody for the path that's going to take, the next few months, 6 months, 12 months, because there's going to be a lot on that, first year. And then all the other things we roll out for them, I'll let Johnny talk about, because it's really this intensive case management and responding to them as they find who they are and how they want to make their way in the world. And that's a bigger part of recovery.
Mm-hmm. Yeah. Well, I like unroll. That was nice. I'm sticking to that one. I mean, for me, like some medical professionals, I view buprenorphine and Suboxone as an engagement tool, and some people kind of give me crap about that because it's a lot of things. It actually prevents death.
So what are buprenorphine and naloxone? What is that?
It's Suboxone.
Right. So how does that work? Just for folks who might not be aware of those medications.
Well, let's do the doctor one on that then, for sure.
Well, yeah, I would be, I wouldn't be doing my job if I did not talk about these medications. So a lot of it seems overwhelming, right? You have this drug that is a perfect storm and it's affecting everybody across all the spectrums, but there is a lot to be positive about. We do have a medication that we know helps with withdrawals. We know that it saves lives. We know that it helps with long-term recovery. And it is something that you can prescribe. There's actually multiple medications. There's ones, methadone is one, buprenorphine is another one. It comes often in the form called Suboxone, but there's a long-acting injectable, which I really love to use for adolescents. And then...
So you get a shot once a month, and then if you try to take fentanyl, you won't get high.
Right. So these medications are all about how can we both prevent people from going into withdrawals, help with cravings, and then block the effects of the opiate. So, and then methadone is, I think, did I say it? I got methadone, buprenorphine, and then naltrexone. And that one also comes in a long-acting injection. And so we are using these. A lot of it is, can we save people's lives, right? We know when there is one of these drugs in their system, they are less likely to die. And so that is absolutely what we're out there doing every day. But there's a lot that is not about the medication in this recovery. That's maybe how they come in the door. It's an important thing that I talk to them about, but that's not what our entire relationship is based on.
And so then Johnny rolls up on his bike.
Yeah.
We have this medication, and also I can help you with what are all of the things that you've helped people with to help them recover, Johnny?
Maybe I shouldn't say that on the radio. There's just so many things, but I really just haven't done this work to do death prevention. I didn't plan on it being death prevention. I argued with Caleb Bantagreen all the time about not wanting to do death prevention, and here we are. But I'm not trying to go to work every day to do death prevention. I'm really not. I'm really trying to go to work and spend some time with some young people that a lot of young people, they're not, the whole thing about overdose and death, they don't think about it like we do. They're young and they're adolescents. So we're all, and their parents and loved ones and family, they are all about like really, really like worried about them dying, because as we know, a lot of people are dying. Not that many of our young people are really like as concerned as everyone else. So we're trying to bring that same concern to them. At the same time, just doing a lot of, we just like phones and Orca cards and like, what are you doing tomorrow? All legal criminal justice stuff, just walking through that with them. But when someone's in withdrawal and you call the doctor and the doctor's like shows up or is able to prescribe a medication, that withdrawal is then they feel better. And it's their first experience with something that is making them feel better. That's not the drug they were seeking. And that's pretty powerful. And we see it all the time. We witness it a lot. And then it's more, as we go down the path, people, go to treatment, they relapse, they struggle, they come back, they get arrested, they get pregnant, they do a lot of different things. They go to school, they drop out of school, they graduate, all the things that we try to just kind of walk the rest of the way.
You're there with them step by step. Okay, you're pregnant now. How do we help you with that? You relapsed. How do we help you with that? You ran away from treatment. How do we help you with that? All the way. So
we talk about that relationship. It doesn't work if they can't come back.
Thank you so much. We're going to have to leave it there. If you have questions for them, write it on a card, give it to Kamna. And with that, I would like to invite up, give a round of applause. Wonderful work. Okay. And with that, I will invite up our next two guests. We have Malika Lamont and Deontay Damper. So they hold a lot of different roles, but tonight we're going to be talking to them in their capacity with a group called Vocal Washington. And so Vocal Washington organizes low and no income people directly affected by the war on drugs, homelessness, mass incarceration, and the HIV/AIDS epidemic. And they create an opening in policy discussions for those folks and their insights. So right now we're going to zoom out and we're going to talk about the big picture policy solutions. Thank you so much for joining me, both of you.
Thank you.
Thank you.
Yeah. So I have some background for the audience before I get to the first question. So they were both involved in a task force called the Overdose Emergency Innovative Recovery Task Force. And it included a lot of people from a lot of different disciplines. You had lawmakers, right, treatment folks, drug users. And so they created a set of recommendations about how to solve the overdose crisis.
Yes, absolutely. Now, you did an okay introduction, but let me give it to y'all
Okay,
on
please.
what it looks like, right?
Let's hear it.
I've been living in this community since I was a kid, and I moved back here in 2018. I have lived experience. I've spoken on many panels, but I had a lot of friends lose their lives during the pandemic. I reached out to a community person, Miss Lisa Dugard, very grateful for her. And I wanted to try to come up with a way to stop having everyone have all these different conversations about how to show up for our community. So she had someone come on the team to help me with that process, and it just didn't glue together, because as you are doing this process, you don't need to just have cultural competency. You have to have cultural humility and understand the impacts of what's happening with the community. Then I met this wonderful lady by the name of Malika Lamont. And when I give it up for her. Because when we talk about people in community, it's not just when people just look at you, because I can just look around you, but she sees you. She sees the impacts of where we come from and how we can actually strive to become a unit. And that's how we became the OER task force.
Thank you. Thank you for that. Yeah. Okay, so the OEIR task force, right? So you laid out a vision that's very different than, say, just giving out naloxone, although that's important. And by the way, we have some. Did I mention that? We have some over there. Take some home with you. So lay out this vision for us. If we were to peer into your vision of how do we actually stop overdoses, what does it look like very concretely?
So of course, you want to stop people from dying, like Johnny talked about earlier, and Dr. T. However, how do we make it so that people can live? And so we wanted to look at it with the social determinants of health lens and look at the disproportional impact of systems upon marginalized people, people that use drugs, people of color that use drugs, and what would it take in order to create a systems-based approach that would support life, and that would support health, and that would support wellness. And that's what the frame that the OEIR task force took. That was important to me that we take that frame. I want to prevent death, but I also want to support life. I want to look at recovery as not just abstinence, but at all the different domains of an individual's life so that we can go forth and have a healthier community all around. And with the harm reduction approach, that means that we look at all of the harms, what's happening in the community as well as what's happening at the individual level. I like to try and deal with big H harm reduction. I'm all here for the like smaller H harm reduction, meeting people where they're at in the cycle. But the 5 areas that we focused on were housing, treatment expansion, harm reduction services, decriminalization and legalization, and community education and stigma reduction.
Okay, can you say that again? Just one more time slowly.
Okay, sorry, had coffee on the way up here.
Yeah.
Anyway, so housing, treatment expansion, housing, treatment expansion, harm reduction services, decriminalization, legalization, and community education and stigma reduction. And we wanted to look at, in the housing sector, creating stable housing that is appropriate for people where they are and their cycle of behavior change. So not just abstinence-only housing, but also meeting people where they are in their use and recognizing that people have lapses and in their abstinence if they choose to go that way. And if they choose not to go that way, they should still be able to have a respectful, safe place to live that is appropriate for them. We also we talked about expanding geographically the availability of harm reduction services with the recognition that harm reduction is under attack in South County, and that's disproportionately impacting Black and brown people. We also wanted to talk about safe supply. So, towards decriminalization and legalization, having a safe supply. We have a poisonous drug supply, and it is not the fault of the drug users. I know I'm over 2 minutes, sorry. Anyway, and then also making sure that there's treatment access expansion for the most effective treatments that work for people that have opioid use disorder or use opiates and are at risk of overdose. So methadone, that's one of the more successful or easy substances for people to use that are using fentanyl. Buprenorphine, it can be hard it can kick them into withdrawal because it's so much more potent. So being able to expand without having a brick and mortar space, because we know that there's a lot of NIMBYism out there as well. And having more peers to work with people, not just certified peers, but people with lived and living experience, and paying people a living wage in order to do that work and giving them the support that they need in order to support their community members.
Thank you. And if you want to read the whole report, at the bottom of this resource sheet, I have a little link tree, and so it's linked in there along with a lot of other resources too. So there's a term that I want to just dwell on for a second because it's very important, and I want to make sure that we're all on the same page when we talk about harm reduction. And so harm reduction, and correct me if I'm wrong, so for example, the harm reduction approach is, say, for drug use, okay, you're using heroin. If you use a dirty needle, you can have major infections. So how about a clean needle if you would like one? Here it is. Or for example, you can probably see this all over the place, condoms, free condoms. Instead of no sex, how about if you're gonna have sex, if you want it, here's a condom. How about a condom? And harm reduction there, and we'll talk about the NIMBYism in a second, there's a lot of controversy. It seems very controversial. I've read the research. It's actually, there is a long, well-established body of research behind it. So when we're talking about harm reduction, say, safe consumption sites or syringe exchanges or, handing people out clean materials to smoke or to use drugs, a lot of communities, I hear a lot of pushback from, well, we don't want drug users here using. We don't want the litter, we don't want the crime, we don't want the disturbance. How do you address those community concerns about the impacts of what they see of harm reduction in their communities?
So harm reduction is programming. I want to kind of make some distinctions here. Harm reduction is an overarching philosophy, and there is also harm reduction programming. And I think that it behooves us all to have an overarching philosophy of harm reduction in our lives, and being able to meet others and ourselves where we're at in the cycle of behavior change, and to provide support, and that we have a moral connection to each other in order to improve the quality of life for everyone. And that we take the harm seriously about what is, about the way the prohibition-based system impacts people that use drugs. But when folks get up in arms about, harm reduction programming, those are real concerns. And as I said, harm reduction takes the harm seriously across the board. And I will say, as a person that has run harm reduction programming, every single place that I ran harm reduction programming, we improved the neighborhood, and then we got moved along because gentrification was not far behind. And that's a trend that I have seen quite frequently with harm reduction programming. I think that there's a lot of fear around it, and I think that also folks do see the symptoms of the disease, and I'm not saying substance use disorder is the disease, I mean the disease of stigma and prohibition upon people who use drugs. So I just want to be real clear about what I'm saying. And so like the needle litter, that's a real thing. But when you don't have adequate level of service in order to because harm reduction programs are often the most underfunded programs. And so when you don't have adequate access for the demand, then you are going to see the consequences of that in your community. And that we need to change the way that we look at things and be more honest with ourselves about what's actually really, and educate ourselves. That's where part of our plan is about community education. So that people are aware of what's actually happening, that we actually need to make more investment and make things more readily available.
Speaking of readily available, you look at the areas like the North End, and they have so many different harm reduction sites and access to care. And then you look at areas like Federal Way, which is number 2 in overdoses, and they'd have little to no resources for that. And if you think that that is by chance, it is not. So I just look at that and just think about my community, which is filled with Black and brown folks and other communities that the BIPOC community stands. We're out there getting sent to SCORE as a space of our harm reduction. Which keeps us going back and forth and down that prison pipeline that's already been set up for us anyway. So.
And I would encourage folks to, learn more about what actually happens at syringe exchanges. I think oftentimes, I can speak for myself, the syringe exchange that I used to run, I invited community members. It was a safe place for everyone to come. And most syringe exchanges take that philosophy that if you can come in with a respectful attitude, you can learn more about what's happening in those spaces. And oftentimes, people that even wanted to come and criticize the work, they oftentimes were like, "Can I volunteer?" And I'd be like, "You most certainly can." Anyway, so because they need to be up to scale of the need, and we don't have that at this particular time. And what you're seeing is not having adequate scale of these programming.
So what you're saying is, so the community is afraid of impacts, which are real impacts.
Right.
However, if you fund the services adequately, if you support the services adequately, then you can mitigate or prevent those impacts to the community.
Right. And I would encourage folks to learn about Insight up in British Columbia. That particular area has gentrified more quickly than most places in BC because the improvement to the downtown east side, to the atmosphere, because people have a safe place to go. Overdose prevention sites save people's lives, and they also engage people in the uptake of healthier behavior and engage them with healthcare services. So, it would behoove folks to learn more about things. It's one thing to get angry about stuff, but I think we all hopefully would want to challenge ourselves to move beyond anger and into learning.
We have a supportive crowd here tonight. You mentioned decriminalization and legalization. I want to talk about that for a second, and I have a comment from a KUOW listener. So this is from Bill in Ravenna, and I'm paraphrasing. We voted to legalize weed because as a community, we realized that marijuana should be treated differently than other drugs. However, over the past 10 years, it seems that there's been a move to decriminalize other drug activities that we never voted on. To treat meth and illegal opioids the way we treat marijuana does not make sense. People who sell life-wrecking drugs, whether on the corner or from a corner office, should go to jail for a scary/draconian amount of time. What's your response?
Malika?
I respectfully disagree. Because decriminalization and legalization are not the same thing, one.
What are each of them?
Okay, so decriminalization moves towards not criminalizing the behavior of using drugs and not criminalizing the substance, like personal use of a substance, generally speaking. And it actually opens pathways for people to engage in more services. I think we all know that if you're sneaking to get that bowl of ice cream at 2 o'clock in the morning, the fact that you're going to trip down the stairs is highly more likely than if you just turn on the light and walk downstairs and go get yourself something to eat. Not that I'm saying that, ice cream and substances are the same thing, even though oftentimes the first addictive things that we were exposed to were salt, sugar, but that's all right. You don't want to hear me on that.
So decriminalization is I can use. I'm not going to get a misdemeanor, a felony, something like that.
And I mean, a misdemeanor and a felony very seldom improve people's lives. The stigma that comes along with the criminal legal system record does not improve people's lives. It makes it harder for people to get housing. It makes it harder for people to engage in other services, and it makes it harder to ask for help if you or have a criminalized activity. Legalization would mean that ideally, it would mean that substances would be regulated, and that a person would have opportunities to engage in care, and that they would be regulated according to how the substance impacts your body. So the one thing that I do agree with Bill about is that marijuana and methamphetamine and heroin are not the same thing. And the level of potential regulation that they need in order to make them safer for people to use is different. That is, so, but that's something that has to be in a community conversation, and we need to make sure that it includes people that actually use the substances so that we're making relevant policy for, rather than doing something without the individuals that are using substances. Mm-hmm. I think that a lot of folks have this perception that it's like, harm reduction is a free-for-all. It's not. Harm reduction means that we meet people where they are and we engage with them, and that but a person has autonomy and they're self-determined, and that we work together collaboratively, and that we, like I said, we recognize the harms of all of the intersections of these systems. Racism, classism, all of these different things. I would encourage everybody to go to the National Harm Reduction Coalition website, look up the principles of harm reduction, and educate yourselves around, if you don't already know these things, anyway, about what harm reduction actually is.
So I want to move to you, Deontay. You have living experience. Speaking of people with living experience, you have lived experience of being addicted to meth, and now, as you said, you know a lot of people who are dying from overdoses. And in South King County as well. And I'd love for you to touch on that too, to just describe the situation there. From what we talked about, from these different solutions, what would have been the biggest help for you and your friends and their health and well-being?
I think well, I think about a friend. I would just name her G. When I moved back home, I was so excited to see her, but she didn't make it back on the plane from Vegas. She died from an overdose. As the months continue to go on throughout my space, I know I make it look good right now because I got on some nice shoes and all that stuff, but the pandemic put me into a space where I relapsed. But I did not have time to get the care that I needed. So I kept working. And then I relapsed again. Then I kept working because my community needs me, so I was fine. And I relapsed again. The pandemic hit so damn hard that I did not know how to give the tools back to myself. I'm standing in front of you, a part of very many different organizations, and very happy to be a part of this one. But I am a person in recovery. I'm a person, just like everyone else here, that has dealt with isolation that you cannot even calculate. Raise your hand if you ever felt alone during that pandemic, or just period. So how do you think someone living in the spaces of addiction feels, that may use substances feels? I'm so happy that I work with an organization that is continuing to show up for people rather than saying being there. I appreciate this person that is my friend that stood by me through that space. And we will continue to stand by everyone in this community that needs a fentanyl test strip, that needs a needle exchange, that wants us to talk to other housing authorities and other DOHs about how to show up for our people, because we're going to be there. It's that type of support, and that's all I have.
Can we give Deontay a round of applause? Now, day by day, as you work through your recovery, relapse, work through your recovery, what is the biggest help, or what helps you most?
What helps me most? Because I would say Beyonce, because the album just came out.
Wait a second, that wasn't in your report.
Right.
You didn't. I read your report. Beyonce was not in there.
I think what helps me the most by my recovery is how community is starting to come together and start having more conversations. See, black people didn't think black people did meth. And as many, and as a member of the LGBTQ community, there is a big space, a conversation that we aren't having about methamphetamines in our community. And that in the areas also comes to prevention. And there's so many different sectors in that we need to have that conversation on, especially when it comes to our youth and seniors that are using fentanyl. And I think that it's just, sorry, soapbox, I'm jumping off of it. But either way, I think that either way, having conversations and assisting community members that may have been against, help them unlearn those behaviors to realize that you have to let down that guard and really show up for community. So it's community support, people being there for you. Absolutely. Well, not just for me, just for everyone. I mean, yeah. Shoot, yes. Oops, I am so sorry.
All right, well, we have to leave it there for right now, but if you have questions, we'll keep the conversation going. I'm looking forward to continuing this conversation later. Big round of applause. So you can. And I would like to invite up our last guest before our Q&A section. This is Laura Okoloko. There we go. Okay. She's a therapist and a social worker who specializes in counseling families impacted by addiction. And I wanted you all to meet her specifically because she has very, very good concrete advice if you have somebody in your life, in your family, who is going through an addiction right now. And what she has to say is very different from common ideas, or we might say myths, of, well, you have to kick this person out, you have to let them hit rock bottom, or you have to strong-arm them with an intervention. And so, Laura, you use an approach that's called CRAFT, which stands for Community Reinforcement and Family Training. Can you describe that? What are the key points of CRAFT?
Yes, so CRAFT is a series of skills, and they're skills that families can learn. And There's been a couple decades of research about craft, and what it tells us is that it's more effective than a traditional confrontational intervention, and it's also more effective than detachment-based strategies. And so families can learn these skills and use them with their family member, and the goals of craft is to help the person with a substance use disorder reduce substance use and accept help, and to help the family members reduce their own distress, kind of measured often as depressive symptoms, whether or not their loved one's ready for change.
And what are those skills? What does that look like?
So the skills that are most effective for the actual treatment engagement are pretty straightforward. It's teaching positive communication to help families reduce conflict, but increase direct communication about the substance use, and helping family members know that it's okay and actually helpful for them to be treatment system navigators and advocates for their loved one, and to help them access care. So that combination of communication and kind of facilitation is really effective.
So now, drug use can create a tremendous amount of chaos in a family. If the solution isn't cutting somebody off or kicking them out, what actually works? What's an example of how these skills have been put into practice to help somebody get into treatment?
Well, I mean, we just heard about kind of the impact of isolation, and I think that's what's wrong and outdated with a lot of the advice that's given to families. Often focuses on removing protective factors like stable, safe housing, relationships with family members. So we don't want to increase risk factors or decrease protective factors for people.
And so, protective factors, risk factors. Just break those down for us.
Yeah, so there are a lot of risk factors and protective factors that may not be within the control of a family, like community-based ones. But there are quite a few that families can have an impact on. So an example of a risk factor is social isolation.
And this is something that pushes somebody to use more or pushes somebody to use less when we're talking about the risk or the protection?
Yes, or maybe increases someone's risk of substance use becoming a substance use disorder, for example. Or risk would be, especially since we're talking about fentanyl, is overdose and death. So families can have quite a bit of impact on either facilitating or introducing protective factors like safe, stable housing, which a lot of families feel stigmatized for being willing to not only let their loved one live with them, but even to be in a relationship with their loved one during chaotic substance use. But generally, for most people, family relationships are protective.
And so you're saying, yes, you can and should allow your family member to live with you, even if they're using?
I'm saying it's perfectly okay if that's a decision you want to make for your family. So you don't have to let someone live with you, but there's nothing wrong about that. It certainly isn't. I've heard a lot of my clients talk about some of the terrible things people have said to them, like they're enabling their loved one to death by being loving and kind and supportive, and that's just wrong.
Yeah, and I want to tap into something you're saying here about the relationship and building the relationship, the strength of the relationship, which also Deontay talked about, the support, the community support, that's something that's really key, right? I mean, and Johnny is an example of this, that relationship and somebody to help you navigate these things and help you to address the various areas in your life that you need help with, right?
Yes, and relationship improvement is one of the craft skills, because the more improved the family relationships are, the better the family has positive influence on their loved one.
And so what does that look like, for example?
So some of the craft skills, for example, are just some basic relationship improvement, like being willing to spend time with your family member, or have conversations that are not centered on drug use all the time. Learning how to communicate more directly, and not having to use anger, for example, to set limits or to have boundaries that doesn't have to be delivered with anger. There's also some behavioral strategies in craft, like if your family member is engaging in a healthy, positive activity, then you might want to react in a way that's positive and rewarding to that. and that you can, sometimes families are accidentally rewarding the behaviors they don't want, and so they can learn to not do that.
Like what?
Well, I think this is one of the ways I see people make a lot of shifts in when they're using craft with their family member is to move away from all or nothing approaches, and you can have boundaries or limits or allow natural consequences without punishing someone, being angry with them, withdrawing your relationship, withdrawing support. So, for example, if your family member had their car towed because they took their car with them and were using heavily, you can not solve that problem for them and say, you know, that sounds stressful and I'm sure you'll figure it out. That would be allowing a natural consequence. You can do that without saying something mean or being punishing or saying, I can't talk to you ever again.
So you mentioned enabling as a word. Oh, you just made a face. Did you guys see that? Her face just went. So I have a question from a listener. This is Rebecca in downtown Seattle, and she says, the main point for me is the difference between harm reduction and enabling. Many people in Seattle don't seem to know the difference, and that's very dangerous because of fentanyl. People can die from enabling in 15 seconds now. What do you say to that? What's the difference there?
So I think I'd be curious about, people define some of those terms differently, so I'd be curious what enabling means to that person and what harm reduction means to that person. I think anyone I know that uses harm reduction as their philosophy of care is really passionate about saving lives and reducing risks, and that's what harm reduction's about.
Mm-hmm. In a family, I understand that you have some ideas about how families can incorporate harm reduction into their relationships with their family members or friends who have an addiction. What would that look like?
Yeah, I think we've been hearing about how harm reduction can be specific programming, but also a philosophy. And so harm reduction also can be a philosophy for psychotherapy services as well, not just public health approaches. And so I find harm reduction to be a very helpful guiding philosophy that's also in line with my ethics as a clinical social worker. And I've heard harm reduction described as compassionate pragmatism. And so for me, having the guiding principles of compassionate, respectful services, treating everyone with dignity regardless of where they are with their substance use, prioritizing safety first at all times, and being willing to do what works and do less of what doesn't work.
Yeah, and so if we've had people write to us who say, you know, I'm a mom, I have kids who have addiction, they don't want to stop using, and I don't know what to do, and they don't want to go to treatment. How might somebody like that use harm reduction in their relationship with their children?
I think first, I think harm reduction as a philosophy, differing from some of the more old school methods of that speak about things like codependence or detachment or those other things, I think can encourage people to just stay in respectful, loving relationship with one another. And I think that is the most helpful thing that families can do for one another when someone's experiencing addiction. And being in relationship doesn't mean that you have no boundaries for yourself. It doesn't mean that everything's okay with you. And it doesn't mean you approve of everything that somebody's doing. But you can stay loving and kind, and that's not enabling.
Got it. So this is the last question, then we'll go to Q&A. In your practice, when you think of your biggest success stories, what's worked best for those clients of yours, and what are sort of your best tips or advice that we can learn from their experience?
I think success doesn't look the same to everybody, and people have a lot of different paths to recovery. But to me, the thing that's always present in the successes that I see are people willing to stick with each other, and that ultimately when that young person is ready to make some change, even if it's not exactly the change that the family wants, on the timeline that the family wants, in the way that they want, that they see their family member as a loving resource. And you can't go to somebody for help if they won't talk to you.
Got it. And that timeline can be very long, too.
Yeah, and as much as I have a really big heart for harm reduction, I also acknowledge it's really, really hard for families. Families want people to be in action stage of change all the time, and they don't want to be in the gray. It's really, really hard to stick by someone when you don't approve of all their behaviors, and when you see them doing really risky things, and you see them suffering. And compassion is hard. And I think to have compassion is to feel with somebody, and those things are all really hard for families. So I don't mean to say that this is an easy thing to do. But I think it saves lives and it saves family relationships.
And you've seen it work as well.
Yes.
Yeah. Mm-hmm. All right. We're going to leave it there. We're going to move to Q&A. Quick round of applause for Laura. Oh, you stay up, and I'm going to invite our other guests to please join us here. And one of you will get this chair, and then I move over here. Okay. Thank you, Kamna.
Anyone have any more cards?
Okay. These are fantastic questions. All right. Okay. So, sorry, I'm trying to reduce feedback. Here, I stand right here in front of everyone. Okay, first question is from Julia in Montlake Terrace. Julia wants to know what can or should be done to bring down overdose death numbers, and specifically, I know we've talked about this, but specifically if you had to prioritize one thing to do first, what would it be? Just quickly down the line. How about we start with you, Malika?
I think that definitely connection through, harm reduction activities. You want to make sure that people have access to naloxone. That is something but it doesn't stop at naloxone. And I would say housing too. I think they're 1 and 2.
You took mine, Malika. Mine's is housing. Well, I thought mine's, in my opinion, I think it would be housing. I mean, we see a lot of our community members are getting thrown under the bus, and they're a part of this narrative. But I think that one of the things about it, once we're actually to help everyone in our community that may be without a home or houseless, we can start navigating our spaces to help towards prevention, as well as helping them get access to care.
Since the Narcan's over on the table, and we're still going to keep on pushing for that, but educating, only a lot of us just knew about overdose because it was close to us in our community and who we worked with, and then it went out, and then it went out, and then it went out. Now it's going further out, and then and soon it takes until someone dies in a far out suburban or rural community, and they're like, oh man, what happened? Maybe that stuff that they're handing out over there, we should have some of that. And so that education, how education and informing and helping people, again, with the stigma thing, just be like, actually, it's fine for us to have these things around, because all our people actually do them.
I would say free, accessible health care and stable housing. And I think especially for substance use care, every once in a while the conversation crops up about mandated treatment, but we shouldn't be talking about mandated treatment before people can just access treatment when they want it.
Ooh, wow.
And I think I would say what everybody already knows is there's not just one thing that leads people down this path, and it's silly to say that there's just one thing that's going to fix it, but all of us here know that having access to like a dignified way to live, so that's housing and healthcare and connection and community, and so all the things that we can do to support that. I can't say more.
Thank you for that. Sorry. So speaking of reducing barriers or accessing services, we have a question that says, what are your recommendations on how to reduce barriers to accessing Suboxone services? We have prescribing providers in our clinics, but relatively few patients.
Oh, where's this from? Is there a location? No. Oh, it's somebody up here.
That's it.
Somebody here.
No name, but you could stick around later and
Oh, yeah,
maybe
no.
talk to these folks.
I was gonna say, give us your clinic information. We'll help you. Anyway, get some folks. And
So the answer is, after we're all done talking, come down here, talk to these folks. We can create some
We
connections.
have thoughts.
Yeah.
yeah, and I
Yeah.
also think that, I mean, this is something that I've seen in my community as well, is that you'll have people that are waivered, but they won't, and now that we have more massive wavering available with the MAT for all, you know, the MAT Act that just passed with in the House and Senate. Anyway, that it's making it to get rid of the waiver, but making sure that physicians also are have that cultural humility and competence to be able to work with people that are using drugs, because it's one thing to have the ability to prescribe treatment. It's a different thing to be able to engage with people in a way that they will come and engage in treatment in your facility. That in a clinic that I work with in Thurston County, one of the problems that we saw in our community is that we were very low barrier, and once people got more stable and we tried to move them on to other clinics, the way they were treated in the broader community was really disrespectful. And we have so much stigma around substance use that if you were stable on your diabetes medication and went to a different doctor, they're not going to change your dosage. But when we're talking about, you know, medications to treat substance use issues, that happens quite frequently, and it destabilizes people. So, you know, those are things to think about as well. So making sure that there's competence in your clinic.
Oh, and sorry, when she's talking about waivers for these medications that are used for opioid use disorder, you have to go through this big long process, right? You have to get certified, blah blah blah. You have to get federal approval, right, to actually prescribe these medications to people to use for treatment for their addictions,
Yeah,
right?
there's a many-hour process, so that there is some training involved, and they have removed the training, and it just depends on how many people you can take care of. So under a waiver, you can take care of more people than right now. There are some people you can prescribe it without a waiver, especially, and it makes it more accessible for people who wouldn't have access otherwise. But I think Malika speaks to the main point, which is it's not the waiver, it's not having a waiver provider that makes it accessible to people, because if you think of all the people that anyone in this room has to talk to before they see that doctor, those are all the things that people have to go through. They have to, one, know that they're there. They have to talk to the person on the phone. They have to be able to call them and have somebody understand that they're coming in, especially if they're in crisis, and they say, okay, well, now you have to come in and establish care and tell us all about your life. And then after that, you can meet the waiver provider, and that might be a month down the road. And for somebody who's trying to get help now, that door is not open, and so they won't go back there. And we have people who've seen the waiver providers, but they couldn't get their prescription. So there's just like layer after layer. That doesn't mean we don't need more waiver providers, especially in like pediatric practices and family practices, but that might not be a space that people feel welcome coming to, depending on where they are in their addiction. And so thinking about not, is this space friendly for all the people that are already coming, but is it friendly for the people that are not showing up, and how do we make that happen?
And I would add that abstinence-based services have been a barrier for a long time for people accessing care. So requiring that people are abstinent up front in order to get ongoing help with their substance use disorder is a barrier.
When I was learning about it, I was told that if they fail your level of treatment, so if people are relapsing, then they're not successful on their treatment and you need to move them onto a higher level of care. So now we're actually just disrupting the relationship that you've tried to build and say that something is wrong with them rather than something wrong with the system and how we can support them. And most of the time, most doctors don't know how to send them to whatever that higher level of care anyways is, or how to navigate it. They just say, here, go ahead and, you need a higher level of care, try treatment.
And also, it's really important in traditional practices to make sure that everyone within the practice is trained to work with people that are experiencing substance use disorder or using substances, because not every person who uses substances is in disordered use. And making sure that everyone is trained, because the people that people see first are the front desk. And then, the medical assistants, the nurses, and the doctors, and everyone in the clinic is trained, not just the waivered provider. It's creating a more hospitable environment for people to engage in for healthcare. That's crucial.
Next question here. Where are we? Sorry, somebody told me to sit in the audience for less feedback, but this doesn't sound like less feedback, does it? Oh, all the way up there? Check, check. Check, check. How's this? Less feedback? Okay, all right. Thank you for bearing with us. Where are we, Seattle, the whole region, when it comes to safe injection sites, safe consumption sites?
We don't have them. Anyway, but one of the things that we are working towards are drug user health hubs. So working with places that people already engage with and creating health hubs for people that use drugs and making sure that they have a whole spectrum of options, including, a safe place to be, as well as, healthcare and, access to all of the supports that a person needs in their life in order to become more stable. But no, we do not have overdose prevention sites proper in this state or in Seattle or King County at this time.
Do we have those health hubs?
We're in the process of developing them, but we do not. We have places that people are already going to. The goal and the plan is to expand the services and the hours and the staff of those particular places. But it's a funding issue that. It's not. I mean, if we had our druthers, we'd snap our fingers and have it all. But but that's not where we're at. We don't control that. Vocal doesn't control that.
Got it. And Malika, while we're with you, can you explain your mention of harm reduction being under attack in South King County? Just want to understand better. Thank you.
Last year, Vocal Washington for Overdose Awareness Day, International Overdose Awareness Day, we did a direct action there to protest the city's decision to shut down county level services in Federal Way proper. And within that time, overdose actually increased. It was when the blue pills were becoming much more available for folks. So it was like a perfect storm of the people didn't have access to harm reduction services that I might say are not up to scale or adequate. And that's not the county's fault. It's a funding issue. And then also the introduction of fentanyl into the community. The overdoses spiked as a result of that policy decision by their mayor and the city council there. And they have now doubled down on a policy to make it illegal for people to smoke fentanyl outside, which is very much targeting homeless people. Nobody's using substances outside because they, want to. It's because they don't have a place to go. That's the beauty of overdose prevention sites, is that it would create a safe place where people could go, they could be observed, they can engage with healthcare providers if they want to. It's a safe place to be, and it's a place to be observed if you encounter, if you end up being in an overdose. And they've been successful in New York City, and they just got sanctioned in San Francisco. In New York, they have had no people that have died, and they have been able to, and they actually don't administer naloxone that frequently. They monitor people's respiration, and they're able to take care of them. So I think these are things that, we really seriously need to think about. And it's concerning. Vocal doesn't advocate for one candidate or another, but it's concerning that the same mayor that has made these policies that have targeted vulnerable people in federal way is running for prosecutor for King County. And that would be, in my opinion, Satterberg, I think the whole criminal legal system needs to be let me be real clear about that. It needs to be, blown up and let's start over again. Anyway, but because there's so many harmful things that are embedded within it. However, there has been a move towards at least more progressive policies, and it is concerning to me after seeing what has happened in Federal Way, what could potentially happen for all of King County, and especially when we're in the midst of an overdose crisis. They have made a local ordinance in Federal Way to make smoking fentanyl outside a gross misdemeanor, so punishable by up to 364 days in jail. And so, I just want to ask people to really think long and hard about what sort of policies do you want to see in broader King County, and if you want to see what's happened in Federal Way replicated down here. I mean, they're number 2 for overdoses, and they don't have nearly the population that Seattle does, so the rates are through the roof. So it's concerning.
Thank you for that. We have a medical question now. How long can someone safely take Suboxone/Sublocade?
So I think that, I'm wondering. So I think the question is a kind of complicated. So if it's how long can you safely take it? There are plenty of studies that say you can take it safely for a long period of time, a number of years. And there's people who've been on it, and we're still studying it, who have been on it over a decade. And so, that is an active area of research. That is not the typical length that people are staying on it. So when we're talking about safely staying on it, and I'm talking to people, I'm not trying to sign people up for their lifetime. And a lot of it is with their individual goals, but it has a very good safety profile, and it's one that we can prescribe in the clinic without a lot of monitoring, that is safe for them to take and safe for them to have on the streets.
We have a question about withdrawal for young people. I think it's asking for clarification when you're talking about in your practice working with young people in withdrawal from fentanyl. What predicates withdrawal for young people? Are they voluntarily quitting, or is it circumstantial?
Go ahead, John.
No, go ahead. I mean, well, yeah, we'll both go because we get the call, and usually it's quite often they don't have drugs. We work with the juvenile detention now, so they're in detention. Dr. Taryn's been working with the detention facility to just have the medical providers there be able to prescribe and to acknowledge really that these kids are rolling in there, and when they don't seem too good, it's because they're in withdrawal from fentanyl. So it's circumstantial. It's every now and then. With the homeless young people, they'll be around a lot, and then one day they'll just come and be like, "Man, I'm really hurting. This is bad. I got to do something." But that's when we had much more access to them. The youngsters that maybe have never been to a drop-in center or anything like that, they're calling in crisis, and it's because for one reason or another they do not have the substance.
And there are people we've seen that have come through the ED who have gone because they are trying to quit, and they've come and shown up and said, "I need help. I don't know what to do." And there is just a lack of resources for people to do, like, how do I get off this substance? I know I'm going to be in withdrawal. Or some of them didn't know they were in withdrawal. They went to the hospital and were like, "I think I'm sick." And they did not know what it was. So we get those calls too. Sometimes it is voluntary. And even if you plan ahead for it, they don't know what to expect because they have not totally been through it. Some of the young people that we have, or they have run out.
Staying with treatment here, do we need more treatment on demand programs? I assume yes, this person says. Which kinds? How many beds are we short?
Better go over there.
think this is an everybody answer. But yes, we definitely need more access to treatment. I don't think that we do need an expansion of brick and mortar facilities. However, that is not all that we need. We need to be able to make it more readily accessible for individuals to get. It doesn't have to be within a certified treatment facility. I think one of the main reasons that it's so hard to get access to opioid treatment, like medication-assisted treatment, methadone is one of the most highly regulated substances that we have through the DEA, and we have so many barriers for people being able to get access to it. And then, doctors, it's safe in Britain. People can go to the pharmacy and they get dosed. Think about how much we could increase access if we had, PharmDs, because pharmacists are doctors, anyway, and they were able to, if we had pharmacies that were willing to increase access to that mode of treatment. Right now we have to do opioid treatment facilities, outpatient treatment, and it's highly regulated. If we could decrease some of those regulations from a federal level, we could make expansion much better. We do need to be able to have, we do need some, especially in more rural parts of the county and the state, there needs to be increased access to detox management, and that would require a facility in a lot of different places. They don't even have one. They have to come to Seattle, from like Walla Walla. That's not reasonable.
And just to piggyback on what you're saying, when you say methadone is regulated, I was astonished when I was talking to people who are on methadone, because they would say things like, oh, well, I could talk to you like after 9 or 10 because it takes me 2 hours. I have to get on a bus for 2 hours to go to this place every day. I see a lot of people nodding their heads. Every day. Can you imagine people who are not familiar with how methadone is regulated? Like, if you had to wake up every day to get on a bus to go to one specific place, that's a lot.
And if you have any other form of a substance in your body, when they're like so heavily like monitoring your urine, I don't think people understand how much money we spend to monitor people's urine for no other purpose than to have oftentimes a gotcha moment with them, in order to, kick them out of treatment. And that the very thing that they're trying to access and help regulate their lives and for themselves, that we're interrupting people's self-determination and making it very, very difficult. Stigma plays a huge role in the laws, not safety for oftentimes. It's about stigma. And with buprenorphine, it took so long in this country for us to even make it more widely available to people. We had bans on it, like it literally was banned. Part of the reason we have such limited research in this country is because we wouldn't let people get access to this life-saving treatment. And it was the harm reduction movement that fought for that. Like, a lot of people think that they miss that harm reduction actually, there's people in the movement that believe in abstinence, and because that's worked for them. And then, we don't leave people wherever they are in the continuum. They're all a part of this movement. And I think that oftentimes there's this false, polarization or whatever of like, well, either you're abstinent or you believe in harm reduction. And actually the harm reduction approach includes abstinence as well. Mm-hmm. It just means we meet you wherever you are.
So this is a question about the Seattle Public Library. As you may be aware, the Seattle Public Library has banned its staff from administering Narcan. And I did contact the Seattle Public Library's communications folks ahead of this, because I thought this question might come up, and they said that they are currently reviewing their policy. So that's the word from the Seattle Public Library. The question here, though, is does Vocal Washington or the Public Defenders Association have a plan to deal with this obstacle? And how can library employees become involved in helping to change SPL's policy banning employees from administering Narcan?
So, as you'll notice, Vocal Washington brought Narcan to the library. Anyway, and also, but as far as we are involved in conversations with entities throughout county and city government, and Thea actually is one of our members that is involved in, or is aware of some of the different things. She's handling that portion of it, not necessarily as a vocal member, not as your official role, anyway, or your job. But yeah, we have our finger on the pulse with that one. I'll just leave it at that.
Yeah. I remember when we started to really talk to libraries a lot, and with ADAI, and then there was a slow movement. This whole thing is really going to be about the libraries figuring out how to best implement. I went to change in the bathroom over there, and it says we will check on you in 10 minutes. And everybody that works here is super aware of this situation. The question is why, and that's the library may or may not answer that, but they have had people die, I believe, in libraries. And so there's a movement to try to address that. But it's a pretty serious, I remember talking to libraries like 10 years ago. So it's a movement that will continue, I'm sure. And the people do an amazing job with people in this building all the time.
I don't really think that there should be very much more conversation to it. People come into this space because they might not have a space to go. They come in here and they apply for jobs because they don't have that computer. They come in here and with their children because they don't have a proper sitter. And yeah, they may be in the spaces of usage. I definitely, in my own opinion, as a community organizer for Vocal Washington, I definitely think from the security guards all the way to the staff should be able to at least learn preventative ways to assist every individual that may be going through situations of either an overdose or psychosis. That's all.
And to be clear, I wasn't being obtuse in my answer, but I think that they are sincerely reevaluating the policy. We are in collaboration with them, both at the PDA level as well as the vocal level. So, because we're semi-autonomous, we're under their fiduciary umbrella, and we are a part of that organization. But we are separate, also semi-autonomous. So we are in collaboration with the libraries, trying to work with them on that policy and their interpretation of the Good Samaritan law. Because the Good Samaritan law says people that are first responders, that they're covered by a different law if they were to respond to an overdose. But our Good Samaritan law says that everyone can have access to naloxone. And we have a standing order from our state health officer that makes it so that it's legal for anyone to go into a pharmacy and access naloxone and have it on their person. So, or you can go to an organization and get your own kit. I think that, I don't know all the ins and outs of their interpretation, but I think that it is an example of how stigma definitely impacts the way that laws are interpreted and the ways that they are enforced.
Here's our last question from all of you, or for all of you. Comes from Deb in Belltown. She asks, She asks, what are the reasons for pessimism and optimism about where we are right now?
Let's start with the doctor on that side.
I think pessimism for me is that we're not at the peak of this curve. The fentanyl crisis is growing, and a lot of our social systems are not ready for it, including ones that I'm part of. And then optimism is the things I heard here at this panel and in this room. I think there's a lot of community knowledge that we can make use of. And I heard over and over, we're here not just to save lives, but have lives worth saving. And bringing that to people. What can people have after we're just talking about saving lives? What can that future be? So I know that we're all here doing that work, and I get energy from that every day. So I feel very thankful to be here.
I would say my pessimism, because so much of my work with families is focused on helping them help their family member become willing to accept help and to access treatment. it's really demoralizing to see the state of our treatment system. And I regularly have a bit of an existential crisis about why I'm doing that. And I keep doing it. But even to the two questions ago about how many beds we need, I think that even points to the way that we've been taught to think of treatment as inpatient rehab, because there's a lot of money being made there. But that treatment really is not just inpatient rehab, but more people, actually 1 out of 20 get their treatment from inpatient rehab. That's a small minority of people. And our state has, not only do we not have enough beds, but we also have just a workforce shortage of behavioral health workers and social workers. So there's a lot to be pessimistic about. But my optimism is that I've really seen a lot of change in the last decade, that harm reduction used to really be a dirty word, and it's become much more accepted and more mainstream. I mean, it's been the main focus of this conversation, and that gives me hope that we continue to move in the right direction.
Now like people are reminding me of what I get really mad about all the time. I was trying to not think about that for a while, about all the detox and treatment and where to go and what to do and all the systems that I get mad at like every day, like really mad, and the pace in which things happen. I just get really mad. I forgot about them for a while 'cause I was lulled into like thinking about the optimism part. But that part aside, like, it's more sad than I'm pessimistic. I get frustrated with a lot of things, because I want things to happen for our young people. It's just straight up sad. Like, we're about to leave here today, and we won't have to go far, and it's just gonna be sad. And that's not pessimistic. It's just sad. We're about to go, and that part, that part is real. Like, and the optimism. Is that on any given day, and today I got these 2 kids' memberships to the Y across the street, and that's like, oh, this is cool. Like, I'm trying to do this more, just do some, actionable steps. I really like those, Laura, actually a lot. And then also, like, addiction and the part about thinking about where we're at in this fentanyl crisis is like, I don't want to think about it. I want to think about kind of what we can do right here, because this stuff, we have been talking about it, you guys been talking about it, and I think about it a lot. But then on a daily basis, we have some young people, and that they just create optimism. They're young people, and even though all kinds of things are going on, young people tend to just be like young people, kind of funny, and you can do stuff with them and mess around, So that creates a lot of hope.
Pessimism. I don't complain about anything, do I? Okay. Besides Seattle traffic. But I honestly would just say, like, the lack of care in the South King County area. It bothers me that every other month there's someone that we have in our community that's gone, that I went to high school with. They don't get the same assistance as they may get in the north end area of Seattle. While we have the mayor of Federal Way is a part of my pessimism. Sorry, but I'm saying that. But I find hope in the people in this panel. I find hope in y'all, because you're here and you can be able to spread the word to community members about harm reduction, about prevention, and of course this wonderful lady here. And that's it.
Thank you. I find pessimism in that I feel like we fought a lot of battles in this state, and we broke a lot of barriers as far as, like, we were the first place to have a publicly funded above ground legal syringe exchange, like Tacoma, Washington, Dave Purchase, and that there's so much vitriol directed at vulnerable people. It makes me sad that people can't find a place to live because it's so expensive, and that the chasm between people that have resources and people that don't or even if you do have resources, there's still so many barriers to being able to access housing, to access care, to access the things that people need to live, and food. I mean, you know, and it's really daunting to look at all of these different things and then to watch systems that say that they want to change or that they are changing and that they care about, you know, 2020, everybody cared about diversity, equity, and inclusion. And here in 2022, you know, like they want to recriminalize everybody and they want to reinitiate the, you know, like double down on drug war policies and, you know, target Black and brown people. And that gives me a lot of pessimism, but it also makes me really angry. So I choose to fight, but I'm tired. And I think that I want people to care. Like, talk to your friends. I mean, it's obvious y'all care because you're here, but like, talk to the people you know. Like, I'm optimistic because I have people like Deontay in my life. I have people like Chris in my life. I have people like Thea in my life. I have Vocal in my life, Vocal Washington in my life. And I have the benefit of being able to co-conspire with inspired people. I'd include you in that too. I told you I had a fangirl moment when you hit me up with the email. Anyway, yeah, I'm scared and I'm worried about what's gonna happen.
Well, we're going to have to leave it there on that scared and worried note, which I suppose is appropriate, although we have heard lots of useful information and reasons for optimism. So that's the end of the discussion for now. Thank you so much for joining us. Thank you to our featured guests tonight. Let's give a big round of applause. Johnny Ohta, Dr. Taryn Hansen, Malika Lamont, Deontay Damper, and Laura Okoloko. And a big thank you to everyone in the audience and everyone listening in the future.